I am so excited to welcome you today with this amazing panel of ladies to talk about ocular surface disease. And we're going to be talking today about elevating the patient experience in ocular surface disease. I am going to introduce our amazing panel. My name is Julie Shalholm at the University of California, San Francisco. I am joined by literally, she's on my left, but she is my right-hand woman at UCSF. I cannot function without her. Jeremy Seitzman, who I've learned everything I know about dry eye from, who is at the Francis I. Proctor Foundation at the University of California, San Francisco. The amazing Nandini, who is so wonderful and perfect in every single way. And Zeba Syed from Wills Eye Hospital, who is also amazing and wonderful and perfect. And I learned so much from these ladies, and I'm really, really happy that we all get to learn from them today.
I think the take-home message of this slide is that dry eye is really common. Everyone at Academy is in upgaze all day long. My eyes are dry the whole conference. The second most important part is that your dry eye is not my dry eye, is not Dr. Shalhorn's dry eye. We all define it differently. And when we talk about ocular surface disease, it's like saying something's good for a mammal. There are so many different groups of mammals that sentence doesn't make sense. And I feel when we say, oh, that's really common ocular surface disease, sure it is, because it represents so many different diseases. Some of the most common ocular surface diseases that when we talk about is evaporative loss dry eye or aqueous deficient dry eye, the keratoconjunctivitis sicca. And it's really important the words we use when we describe a dry eye syndrome, because it's those words, those findings that lead to those descriptive words that lead our treatment. So there's blepharitis, but that word is also like saying mammal. There's anterior blepharitis, which can be subdivided into several different subtypes. There's posterior blepharitis. There's the neurosensory disorders where the nerve function is not adequate to the cornea. The poor meibomian glands, no one talks about them when they're happy. Everybody's meibomian gland is dysfunctional. The meibomian gland can be inflamed. You can have eyelid margin disease and, of course, ocular rosacea. So I think the question just to put out there, I have a strong opinion about this, but why is it important that an ophthalmologist be managing ocular surface disease? Optometry certainly has a role in dry eye management, but why is it especially important, do you think, about ophthalmology taking sort of command of this space?
I mean, I think as the slide shows, everyone has dry eye disease. I think regardless of what specialty you're in, even if you're comprehensive or a subspecialist, someone's going to come in talking about eye irritation, fluctuating vision, redness of their eye. And I think we're uniquely equipped with an understanding of the ocular surface and all the different modalities of treatment that we could potentially offer, whether it be interventional, pharmacologic, a combination. So I really think that it really optimizes your patient outcomes if you're doing surgery, or it also enhances your patient experience if they come in and you can help them in some way.
Yeah, I mean, just to dovetail off that, the surgical outcomes is something that, I highlight to my patients a lot. And many of them come in, they want cataract surgery the next day. But we kind of have to emphasize, look, we have to get your ocular surface in better shape if you want really good long-term outcomes. And that's a big part of our counseling and conversation.
I love that. And then I'm all over too much information about myself, as Dr. Shalhorn knows, but I for sure had my internal medicine application in and pivoted at the end to ophthalmology. And I know this makes me sound like an ultra nerd, but the correct investigation of dry eye disease really makes you take your MD out for a spin. When you take each little detail out, you're diagnosing rosacea, you're working like a rheumatologist. When you're diagnosing keratoconjunctivitis truly sicca, we've got our rheumatology hat on. So I really love exploring all of the systemic diseases that show up on the eye as ocular surface disease. I love how I got this slide. Am I allowed to say this, that I've been talking about Demodex before it was cool to be talking about Demodex? I love this bug. Everyone has it. Everyone in this room has Demodex, makes you itch a little bit. Not everybody is symptomatic. And that's one of the big themes of ocular surface disease, of when to treat, when not to treat. Sometimes it's with symptoms and sometimes it isn't. Just say, Demodex is prevalent and also at a higher density with more symptomatic patients and in patients with blepharitis. When you have someone close their eyes, I see a fellow in front of me who's laughing because when you meet me, I say, how does a cornea exam start? And my fellows repeat in unison with their eyes closed. Everyone closes their eyes before a good cornea exam. And then what we look for with Demodex is this cylindrical dandruff, this tube that surrounds the lash. I know. Originally, it was called a sleeve, but the company that makes XDemvy has called it a collarette, and everyone in this room knows it to be a collarette, so I will acquiesce to the incorrect noun. What we're talking about is a cylindrical dandruff. The company is Tarsus, and they create lotilaner. This is a drop that's twice a day for 6 weeks, and I'm curious anybody else's experience, but it really does eradicate Demodex beautifully.
It's an amazing thing, you know, Jeremy. I ended up seeing a guy you had treated for Demodex because he subsequently, because of his complex glaucoma history, developed endothelial failure, and you had tried everything with him, like Soolantra. You'd put him on oral ivermectin. He just still had terrible Demodex and a terrible ocular surface. And I was like, man, anything we do for you, we got to get this ocular surface better, with or without endothelial keratoplasty. And I put him on that, and it was gone. It was amazing.
Yeah, I really am so impressed by the results, honestly. I think the data shows it, especially when you look at the outcome of clinically meaningful collarette cure. I mean, eradication is tough, but these patients are often ones that weren't diagnosed correctly and didn't really have a treatment that worked for them. And so if they have eyelid itching, redness, recurrent chalasia, concomitant ocular rosacea, and you see these collarettes, this has been kind of an easy button now to say, hey, you have a 6-week therapy. You don't have to use this in perpetuity. It's well tolerated, and I'm quite sure that you will see some sort of improvement, and I will also appreciate an improvement on exam.
Yeah. And then just from a patient counseling standpoint, I would avoid the term mites. Yeah. I know we love those little plushes that we get, but I usually use terms like, overgrowth of an organism that's already there, something like that doesn't freak them out.
And I'll say, don't Google it. And I'll say, we all have it, has nothing to do with hygiene, et cetera. Yes, there is when you have, I could really talk about these bugs forever. There's 2 different kinds. There's Demodex follicularum, and they grow around the eyelash, and they mate, and they die, and they defecate in a hair follicle. Isn't that exciting? And all of that excrement gets shot up in a cylindrical pattern through the lash. So when you see that sleeve, there's this huge Demodex party happening in the hair follicle. Demodex brevis is less common on the ocular surface, but it's more common in the meibomian glands themselves, which is also really interesting that you cannot see a characteristic sleeve, but could still have Demodex deep inside the meibomian gland. When you look at patients taking XDemvy for a 6-week course, they do report decreased redness, itching, and more stable vision. Which of these tools, when you are looking at a patient with some ocular surface complaint, are you using all of the time of these choices? Slit lamp, dyes, questionnaire, meibomography, osmolarity?
I mean, I think, slit lamp is absolutely essential. That's where everything starts, is a really good slit lamp exam. And then I'd also would say that, structured or not, but asking patients how they feel is also really, really critical. And then vital dyes as well. The other ones, they're great if you have them, but I don't think they're absolutely essential for dry eye disease.
I think it's important to make the diagnosis of dry eye disease simple. And I think it's hard to sometimes invest in all of the diagnostic equipment, et cetera. The fluorescein strip, I think, is so powerful. Put a drop of BSS and put it in the fornix, and it highlights so much pathology, ABMD, keratopathy. Look at the lids and lashes, push on the glands, see what the meibum looks like, look for the collarettes, get a sense of their tear breakup time. You can do all of this within 10 to 15 seconds of your surface exam. And I always encourage my fellows to really do that, because I think you miss a lot if you just go straight to the cataract or straight to the retina. But of course, all of these others do play an important role. I do meibography for a subset of patients, especially if I'm considering some sort of thermal pulsation treatment.
Yeah, I agree. I mean, the slit lamp is really where you take a look and you develop your pre-test probability. And some of these other tests may or may not be helpful, but if your pre-test probability is very high, then having a negative of some of the other tests will not change your likelihood and of your diagnosis and your treatment.
I like what you said also, Dr. Schauer, about their symptoms, because there's a big issue with ocular surface disease. When you see it, will you necessarily treat it? Not everyone with a sleeve gets treated. Not everyone with meibomian gland dysfunction gets treated. So how and why do we make that decision as a community and for the patient in front of us? How do we detect NK? So here's an example. You put in your fluorescein, you see all of these punctate epitheliopathy, commonly misdiagnosed as Sitka. When you see a lot of staining, how are you diagnosing NK? Do you check sensation on everyone?
Yeah.
Yeah, the corneal nerds will. And it's just a point about thinking carefully of when you use proparacaine in clinic.
Yeah.
You don't need it to dilate an eye because sometimes you need to check sensation.
Yeah, so in our workflow in our clinic is when a patient comes in and techs will kind of take them back, vision, pressure, dilate. And that's what we do, what they'll do for, the majority of our patients. And so it is important to be intentional about kind of identifying those patients that you're concerned about NK and making a note on the chart that no drops before seen by the doctor.
And I think it's really important to have a high index of suspicion when you're seeing those patients, with that characteristic kind of staining pattern, patients that have had a lot of intraocular surgery before, patients with poor blinks. I think that, you can bring them back to, check their sensation again, but it is a critical thing.
And then I'll do a very quick presentation without a lot of discussion, just so we can keep it moving. I picked this one just to really emphasize the point, how do we treat and who do we pick? This is a typical academic tertiary care referral for dry eye. It's a third opinion. The chief complaint, itchy, gritty, swollen, light sensitive. It hurts for a year. Has been diagnosed with ocular rosacea. She does have a history of grade 1 lobular carcinoma and is on a medicine that suppresses estrogen. Don't go there. We all know chemotherapies can cause ocular surface. It's not the answer in this case, but good for everyone who thought about it. Just don't go there yet. These are the treatments she's tried and failed: Lipoflow, loteprednol, warm compresses, XDEMVY, Doxy. She's failed it all. She's really symptomatic. And then you start to really wonder, this is also not a neuropathic pain, but you start to wonder about that. She's quite miserable. And this is not uncommon. It's sort of, you're trying to find something, right? So yeah, she has lid margin telangiectasias. If you see the the light reflex of the lamp, you can see she has a thick irregular tear film, right? That goes along with her thick meibum. Sure, I agree that she has some mild ocular rosacea, but a secret to a cornea exam is not direct, but indirect illumination. She has this little epitheliopathy right along the pupil. Can you see that in a little crescent pattern? And then you can see it stains a little bit. And yeah, she's got some dry staining. And you can absolutely see how everybody got to rosacea here. Ocular surface staining, thick meibum, burny, itchy, gritty. By luck, always better to be lucky than good. I flipped her and she has a single concretion. And I thought, it's impossible it's impossible, actually, just one. And I flicked it out and her whole years of symptoms have gone by. And so the point I wanted to make with ocular surface disease is, how many concretions do we all see as a community? We don't take them all out, right? But occasionally they're symptomatic. And that's the case with everything in ocular surface disease. Sometimes a lot of it's symptomatic, sometimes a little of it is symptomatic. So we have to take all of our toolkit, know that sometimes we don't have to treat anterior blepharitis, but we'll talk about when we do, even without symptoms. Sometimes we don't have to, and sometimes we do. And the more we learn about this, the key is to subcategorize what you're treating, to give it the correct name, and then we can go along the pathway of treatment.
All right. So, audience, we're going to, I think, ask you a question. Tell us, for which patients do you assess the ocular surface? Routinely for every patient? Only for patients with known or suspected ocular surface disease? Only if there's a visible problem? Or I don't really routinely assess the ocular surface? That's awesome. Majority routinely for every patient, which I think is really important. Like I was mentioning before, respecting the ocular surface, acknowledging it and assessing it can give you so much information about, what is really bothering the patient, what is the cause of their visual dysfunction. And I think that really stems from, why the air-tear film interface is so important. It's actually one of the most powerful refracting surfaces, right, that we have. And so if there's any irregularity, keratopathy, rapid tear breakup time, even subtle irregularities like basement membrane dystrophy, they really can affect the patient's vision, cause an unstable tear film, and also affect measurements that you're taking for, say, refractive surgery or even cataract surgery. And I think as a community in ophthalmology, we have now started to really talk about ocular surface disease and dry eye disease. We have consensus panels, and we have groups like the TFOS DUCE 3 and the MGD workshop that are really helping us really assess a comprehensive understanding of what is dry eye and what diagnostic modalities do we use and how do we treat our patients with this condition. And I always like to tell my colleagues and my patients that, when I diagnose dry eye disease before a procedure, it's an expectation. When I discover it or tell you about it after a procedure, it's a complication. And I think patients really resonate with that. And I think when they are told they have something before a procedure and that it will affect how they will perform after a procedure, there's a lot more buy-in and there's a lot more compliance about starting therapies and actually sticking with them so that they have a successful operation afterwards. So if they're coming to me and like Julie was saying, like the first thing I ask are, what are your symptoms? Like your classic cataract surgery patient will come and be like, my eye hurts, so I need cataract surgery. But that should immediately cue you into saying, maybe they do have a tear film issue. What is it that I'm seeing? What can I address? And let me try to address that first to see if the pain goes away and potentially if their vision also improves well. And I've actually, chosen to not proceed with some sort of surgery because their primary complaint was ocular surface disease. So, as we're talking about why manage the ocular surface before surgery, there are many studies that show that a high percentage of patients that are coming into your clinic have dry eye disease, but many of them don't actually know they have it. And I think it's always surprising for patients when we tell them that we're seeing something on their ocular surface with our testing that we need to potentially treat. But in addition to, just telling them, I think having visuals for them is very important. Sometimes if I have a topography that I'm taking and I see the Placido-Meyers and they're very irregular, it's nice to show the patient and say, here, these are all those areas that are causing some smudging or blur in your vision. Or if you do meibography, really show them those areas of gland atrophy, dropout, truncation. They understand why those glands aren't producing good oils and protecting their tear film. I think that in my cataract surgery patients, I tend to see more asymptomatic dry eye. I don't know if you guys agree, but my young LASIK patient, laser vision correction patients, many of them will say my dry eye is worse with my contact lenses in. I'm very symptomatic. And so for them, it's kind of an easy discussion to say, hey, well, we should get you out of your contact lenses, but let's also make sure you have a toolkit that you can use after surgery if some of your dry eye symptomatology were to be exacerbated. So, curious from the panel, how does ocular surface disease complicate the management of other conditions, especially your cataract surgery patients, your glaucoma patients?
Well, I'll say that especially now with all the different premium lenses available, a lot of our patients come in very educated about the fact that, their neighbor had this, special lens that, they want now. And so especially, in general, our cataract population, but especially in those who are seeking these kind of higher technology lenses, that those Ks matter so much, especially if you're trying to align a toric lens. These little, just changing their ocular surface and improving their ocular surface health can change your axis, can change the power of the lens. And so all of that matters.
If you were to treat someone for dry eye, how long are you waiting before you bring them back and repeat topography, biometry?
At least a month, usually.
Yeah, I agree. I think that these measurements are so critical. And I think I always tell patients it's important to measure twice and cut once, right? And I think they buy in and they say, okay, I'll do the work so that I can potentially come in.
Yeah, and I think like tear film abnormalities, even subtle ones, can actually be very, very impactful visually. And really seeing that actually now is, and what I've noticed is my post LAL patients, and they come in and they're like, my vision's not as clear, and you refract them, and you're like, there's everything the same. And they're like, people are like, oh, is this like the post lock and shift? And you do their their eye trace and the lens, the internal aberrations look good, and it's really they're just really noticing like fluctuating visual quality from ocular surface disease. And personally, I've never looked at a post-op patient as carefully as I've ever looked at my LAL patients. I think that you guys are probably the same, but really, really actually very subtle tearform abnormalities can have a big impact on visual quality across the board in our young refractive patients for sure, but also in our pseudophakic patients, and it can be very, very significant for those patients that experience that.
Also, as the recipient of that fourth dry eye referral, it's so common to say, when did this start? So many after cataract surgery. And they really assume that increase of symptoms means the wrong lens was put in, that the doctor messed up. And so it really is important to start this sort of anti-inflammatory treatment, and that really addressing the ocular surface before something is done to them, and especially addressing, what I see now before I've done something to you is this.
I've just started, basically, everybody has some degree of meibomian gland dysfunction. It's very uncommon to see people who have perfect meibomian glands. So for basically all of my pre-op patients now, I've started talking to them about meibomitis, starting warm compresses, Bruder mask, something like that, just so that they get used to the idea that I think it does help them, I think, have better outcomes. And then B, they get used to the idea that they have a participatory role in their, the care of their eyes, and that things they could do can make things better. And a lot of them will come back and be like, wow, my eyes actually really feel better after I'm using that warm, that mask. And I'm like, great. And some people come back and are like, oh, I don't use it at all. And I'm like, well, you would do better if you did.
So let's talk about a patient that comes in with some of these dry eye complaints and a fluctuating topography. So this is a 54-year-old woman that I saw. She came in presenting for cataract surgery. She has visually significant cataracts, right eye worse than the left, not refracting to better than 20/80 in the right, 20/40 in the left. Notably has a history of monovision PRK. But looking at her eyes, she has the small orbit, she's slightly ptotic, she has false eyelashes, she has diffuse keratopathy. And we tried to do some imaging for her, and my measurements are just all over the place. I have a high degree of irregular astigmatism in the right eye. You can see in the topographic image there that kind of central island of steepening. The left eye, we're getting less astigmatism, but my techs can just not get an image. They tried multiple times with rounds of drops, and they come to me and they're like, what should I do? And I guess the question is, what would the panel do at this point? This patient's in my chair. She'd like to have cataract surgery tomorrow.
And her cornea is full of keratopathy?
Yeah.
All right. Just take out your, whatever instrument, you don't need a crochet bonnet, whatever instrument you want to check their corneal sensation.
Yeah, she had corneal sensation.
And tears, she makes tears.
Low tear film.
Do you check a Schirmer in that instance?
I don't routinely. Do you guys routinely check Schirmers?
I do not routinely check Schirmers unless there's clinical suspicion. But clearly there's some ocular surface irregularity there. So I would just start off with, tears or some kind of lubricant and see how she does.
Yeah. And I told her, I was like, your corneas look horrible. I can't even get images. I really worry about, what outcome I can get you. She's also a lawyer. So I was like, let's take some time. Let's potentially start some treatment. So I started perfluorohexyloctane. And I also started tears and gel at night. But we have many other options that we talked about. She wanted to keep it simple. She's like, I can stay compliant with 2 drops. I think I'll stick to that. But other options obviously listed here. And she stuck with it for about a month's time. And I brought her back for repeat measurements, and much improvement in her biometry, much less astigmatism in her right eye now, not 2 diopters, but less than 1 diopter. Left eye stays about the same. And I'm getting tomographic and topographic images now. From those initial images, I couldn't really even confirm that she'd had PRK before. She wasn't completely sure. I couldn't get measurements, but here I'm getting Gold-Strand ratio results. So I felt confident in my measurements and was able to tell her, okay, let's proceed with cataract surgery, and I have a better chance of helping you retain the monovision that you loved with your PRK now with in a pseudophakic manner. So we performed cataract surgery, right eye, then left eye, used intraoperative aberrometry as well as manual limbal relaxing incisions, and I decided to do monovision with an enhanced monofocal, and we actually ended up with a really nice result. Her right eye is 20/25 uncorrected, left eye is J1 plus near, and she was a happy camper. But I don't think I would have been able to guarantee any of those results had I acted on my initial set of measurements.
All right, thank you. All right, we're going to switch gears and talk about modern therapeutic approaches for ocular surface disease. And we have a couple of questions to kick off. So first, how often do you recommend preservative-free eye drops for patients with dry eye disease? Great. All right, my job here is done, it looks like. Right. So most people do always or often, which is awesome. We'll talk a little bit more about that. How confident are you in differentiating between cyclosporin treatments and understanding how to maximize patient comfort and tolerability? All right, great. So somewhere in the middle, either neutral, somewhat confident. We'll talk about that in the next few minutes. And finally, do you believe RAS inhibition will play a role in managing ocular inflammation in the future? All right, so most folks are not sure or think that perhaps in specific subsets of disease. So we'll talk a little bit about that as well. All right, so let us start off by talking about different treatment options for inflammation. I'll leave that slide up there, but I want to ask my panels, when you guys are deciding on a treatment or a therapy for patients with ocular surface disease, how much do you match treatment to the dominant mechanism at play rather than simply looking at disease severity? Any thoughts on that?
I think it's very unusual that somebody has one item. And so I'm constantly in my head, in my practice, creating the list of the 10 different areas. And in my head, I will think likely to be causing symptoms, possibly, and unlikely. And I'll address what I think are the likelies. If that doesn't do it, I'll move on to the possiblies.
Yeah.
I sometimes think their symptoms help guide it too. Like if they're like, I have a lot of eye pain and redness, I'm thinking a little bit more inflammatory. If they're saying I'm more fluctuating in vision, I think about their tear film and evaporative dry eye. And then I kind of look for symptoms that, frame that story better. What does their lid margin look like? What does their tear breakup time look like? Am I seeing a lot of conjunctival injection? And so that helps me kind of assess, are they inflammatory? Are they evaporative? Are they mixed mechanism? What medicines are they taking? What are their other systemic comorbidities? And I think it helps put all of those players together in a story.
Yeah, and I think like you said, talking to the patient is really critical to figure out, at least in your head, kind of the you said this earlier, Zeba, like the pretest probability of what's going on. So before I even look at them, it's what do you how do your eyes feel? What are your symptoms? What time of day do they feel worse at? How do you feel when you wake up in the morning? How do you feel when you go to bed at night? Because all of those things can really, contribute mechanistically and tell you kind of what the underlying issues may be. And then, as you said, Jeremy, I think it's so rare to see somebody with one individual thing because, if you're aqueous deficient, then you get inflammation, of course, and you're already prone to inflammation. If you have meibomian gland dysfunction that's really disturbing your tear film, then you can get inflammation too, and you can get conjunctival chalasis. And, if you're not closing your eyes at night or you have sleep apnea, or you're tossing or turning, that can just exacerbate, everything on top of that. So, really kind of looking at the contributing factors and kind of tackling them all at, the major ones, at least all at once, I think this is the way to go.
Yeah. And the answer to that question may have been different 10 years ago. Now we just have so many different. We have a targeted treatment for Demodex. We have a targeted treatment for NK. So now there's actually benefit to identifying each of those, whereas 10 years ago, perhaps we wouldn't have been approaching it that way. All right, next question. Preservative-free matters. So when do you all use preservative-free drops? Is the answer always? Are there times where you don't use preservative-free drops?
In K-Pro patients is the only time, really. No, I think that I really like the preservative-free drops, and I used to be kind of mixed in them because of the individual unit dose could be pretty wasteful, and it can be a hassle for patients to carry that around. But you've got there's a nice schematic of here of the new preservative-free multi-dose bottles, and there's multiple different iterations of this out now, and I've switched to that pretty much exclusively.
Great, and so. There's several different concentrations of cyclosporin listed here. So how do you all decide between which concentration of cyclosporin or one of these other options? How do you kind of decide between these? Any thoughts? Anyone have a favorite?
I think now that cyclosporin 0.05% is generic, that is kind of that or lifitegrast are really mandated as the first line of treatment by many insurance companies. So, if you want to start down that anti-inflammatory pathway, starting with one of them for sure. I think that what is really helpful is the topical corticosteroid. I mean, that gets people feeling better really quickly. It knocks the inflammation down. A lot of patients, once you treat the underlying mechanism behind their dry eye, actually don't need prolonged anti-inflammatory therapy once you get past that initial hurdle. There's clearly something like Sjogren's syndrome that do well, long-term on anti-inflammatories, but that's, I love a short burst of topical corticosteroid right at the beginning.
Yeah. And I completely agree. Most of these medications will take some time to kick in, weeks to several weeks. And so you kind of want something to put out the fire right away, and then you have something that takes its time to kick in and you're in a good place.
And I just want to say to that a lot of people when we say topical steroids, everybody thinks Predforte and Durezol. We in no way need to treat the anterior chamber here. And so there are low potency steroids that can be used really safely that are preserved, unfortunately, but you can balance.
All right, we'll talk a little bit about cyclosporin 0.09%. And this formulation does actually increase tear production. So it addresses the cause of tear deficiency, not just the symptoms. Many patients have found it to be pretty comfortable. The first time patients tried it, 9 out of 10 reported no or mild symptoms. And very, very few patients experienced severe pain, and most experienced very mild pain. And when we think about any medication, we think about its active ingredient and its inactive ingredient, or its vehicle. And the vehicle here, N-cell, is really what encapsulates and brings that active ingredient to where it needs to be. And this technology has proven to be very helpful for this medication. There's also cyclosporin 0.1%. And so the vehicle here, this perfluorobutylpentane is a semifluorinated alkane that helps the vehicle spread evenly and integrates into the tear lipid layer. And it actually improves the lipid layer over the tears as well. So the TFOS DUCE-3 report says that vehicle improves lipid layer grading, which may play a role in reducing tear evaporation. All right, so when do you all consider other types of treatments such as nasal sprays?
One cohort of patients I think that it works in are patients that have a lot of drop burden. So my glaucoma patients, I find actually like an option where they don't have to put one more drop in the eye, less preservatives on the ocular surface. That's worked very well. Some folks are just interested in trying a different mechanism of action that's not an eye drop. So I've had success in those patients as well.
And here, the nerd of me, which is one of the reasons, remember in our practice, I'm just seeing the quaternary dry eye disease. Why everyone gets a Schirmer is because you do need to be able to make tears for this to be effective. So if you know you are a true Sitka, it's not a good option for that patient population.
And I think it's a lot easier to give yourself a nasal spray than it is to give yourself a drop. And there's a cohort of patients that really tend to have very severe ocular surface disease, those with neurodegenerative disorders and Parkinson's disease. And I think this is a really nice therapeutic option for that cohort, which, oftentimes is not able to get anything into their eye at all and really suffers because of it.
And the nice thing about this treatment is it works right away. Like within hours, patients will know if it's benefiting them, unlike other treatments where you have to kind of wait weeks or months to see an effect. And in a survey, over 7 out of 10 patients agreed that they would use a nasal spray if effective. All right, what about other treatment options for neurosensory disorders? How often are you all using synedgermin or amniotic membrane? Pretty frequently?
I use a lot of membrane.
Yeah,
Especially in neurotrophic cases.
Yeah. I totally agree with that. I think that they're indispensable for those patients with severe.
Are you using it alongside synedgermin, or are you doing a course of amniotic membrane waiting and then doing synedgermin?
Similar to the other, sometimes you need something to work sort of faster. And so when you have a membrane over the eye, you'll get a faster improvement of the ocular surface versus the synedgermin that takes a bit longer.
All right.
Hello all, this is Eric Donnenfeld and I'm happy to be here with you. I'm talking today about Reproxalap, a RASP inhibitor, a novel therapy for dry eye disease. What makes Reproxalap very exciting is where it works in the inflammatory cascade. It works on top of the cascade, above steroids and above immunomodulators like cyclosporin and lifitegrast. So it's actually a very potent anti-inflammatory. By inhibiting RASP, you can inhibit pain, redness, swelling, and heat. And the results of the Reproxalap phase 3 dry eye pivotal trial showed marked improvement in ocular discomfort symptom score, as you can see here, with a widening and a p-value of 0.003 and a significant reduction in ocular redness as well. In Tranquility 2, both primary endpoints were achieved for Schirmer scores, with marked improvement of Schirmer scores, with again 25% of patients having Schirmer scores with a 10 millimeter increase versus only 8% in the control group. In summary, Reproxalap is a novel molecule with a new mechanism of action, and it's very well tolerated. The primary sign endpoints of Schirmer scores and Schirmer responding rates were met after the 4th dose on a single day of dosing in the dry eye chamber, and the ocular discomfort and 4-symptom questionnaire eye dryness scores before and after the dry eye chamber were significantly lower with Reproxalap than with vehicle. In conclusion, Reproxalap is a novel molecule with a new mechanism of action. It's something that's exciting. It's certainly very high in the inflammatory modulation chain, and we're looking forward to being approved by the FDA, hopefully in the near future. Thank you all very much.
Okay. All right, now the fun time. We're going to do some round robin case presentations. All right, case number 1. What would you do? Let's start with Zeba. We've got a patient with mixed disease, meibomian gland dysfunction, and inflammatory who's not improving with a single first-line therapy. How are you going to approach that patient?
So in this patient who has mixed MGD inflammatory component, so if someone is not improving with single first-line therapy, I may consider doing a combined approach. And like we mentioned earlier, perhaps a course of steroids, topical steroids to reduce the active inflammation, and then starting one or more of the either cyclosporin plus perfluoroxyactane, and to see if that works better than a single therapy.
Are you going to treat, Jeremy, are you going to treat the meibomian gland dysfunction? And if so, how are you going to do that?
Yeah, I'd probably just give a preservative-free steroid just to calm things down and get them comfortable. And then, with that, I'm sort of treating the inflammation. If I felt like they truly had lid margin inflammation in my meibomian gland, then I'm certainly going to take them down an ocular rosacea route, as we're also, I like to get them comfortable a little more quickly.
So you said a preservative-free steroid. Is that your choice? Like, and how do you get that?
It is the steroid of corneal champions, and you have very limited options. So Lotemax ointment is expensive, but there's lots of workarounds, and that's the only commercially available preservative-free steroid. After that, it's expensive, and you need a compounded steroid, unfortunately.
Do you think it would be bad using a preserved steroid?
No, it's fine. I sometimes feel if somebody came to me with a corneal abrasion, when you have to help the residents the first week, I panic all the time. And I think, abrasion, how am I to treat it? Because I don't see the simple, I only see the refractory. So yes, it would be very reasonable in this case to do fluorometholone twice a day with a little taper and see how they do. If they don't do well, then try to remove the steroid.
Nandi, do you go to a preservative-free steroid as your first line, or do you start with a loteprednol or fluorometholone?
Usually a loteprednol or fluorometholone is just a little bit more easily accessible for the patient. Agreed for a short-term course of, anti-inflammatory. Sometimes I switch up the cyclosporin I'm using, like depending on the concentration that they're potentially starting, trying an alternative, different vehicle that can potentially be helpful for them. I tell patients it's a little bit of trial and error sometimes in terms of figuring out which treatment modality or combination is working best for them, and it's okay to not respond to one. We could certainly try another.
And so, how do you decide if the meibomian gland dysfunction is worth treating? What's your diagnostic go-to for that?
I mean, often symptoms. Like I'll ask the patient, like localize the discomfort, more lids, more ocular surface. And usually when I'm examining them, I look for kind of erythema around the lids, and I look at tear breakup time as well.
I'm a pusher myself, actually. I love to like express
squeezer?
those glands. I am a squeezer.
love
Yeah, I really am. It's great delight when I see tooth. Not delight's the wrong word, but you know, I do like it. Okay. Weird fact about me. Okay, moving on. Case number 2. Okay, let's start with you, Nandini. This is a patient who's presenting with cylindrical dandruff, chronic inflammation, and has failed tears and lid scrubs.
Well, I'll have Jeremy in my head thinking Demodex. No, but I think, the cylindrical dandruff, the collarettes, really, I think we've learned have become a very pathognomonic sign of Demodex and Demodex blepharitis. And so I think for myself, my first line has become lotilaner, really as a treatment that they can now utilize for 6 weeks to see if it's improving symptoms. I was part of the depth panel for lotilaner, which was interesting when we kind of looked at the consensus of how a bunch of us would potentially treat a patient like this. Typically, if you're seeing greater than about a third of the upper lashes with mites, most would go straight to lotilaner. If you have less than that, most of us were typically kind of interested in the patient having a symptom. So would that symptom be eyelid itching? Would it be redness? And if they were having a symptom and the sign, then that would be a reason to then initiate lotilaner, because many times these patients may actually present with no idea that they have Demodex. So it's important to have that conversation and kind of assess where are they in that spectrum. Of course, you could also consider, supplements like lid scrubs with tea tree oil, or even other adjunctive treatments like intense pulse light therapy or blepharoexfoliation.
And Jeremy, why not tea tree oil as your first line?
Well, tea tree oil, it depends how you're going to deliver it, but at higher concentrations can be quite toxic to the ocular surface. I've gone through my love with mites for decades, and I used to tell people to go buy it and go to Whole Foods and get their macadamia nut oil, and I used to dilute it for them. I've really been into mites for decades. But, that now I'll try to eradicate their mite load, and then everyone, if they, people really want to clean themselves. First of all, I don't think you need to have a maintenance regimen for your eyes or eyelashes, but sometimes I'll say, every once in a while, why don't you use a wipe with tea tree just to maintain it? But I think it's better to eradicate the mites first, and then maybe use a very low dose tea tree.
Yeah, and the lotilaner is so safe for the ocular surface.
Yeah.
I mean, I think we've all probably seen patients that are paranoid about their mites and are,
Yeah.
giving themselves horrial toxicity.
It's very well tolerated.
tea tree.
Yeah, it has changed. It's made management much simpler.
Yeah, I agree with that. Okay, let's move on to case 3. Jeremy.
Yeah.
Patient with significant dry eye, and I'm going to say significant corneal epitheliopathy, but healthy lids, they're making tears, you don't think there's an inflammatory component. What's going on?
So we see an epitheliopathy.
See an epitheliopathy.
But everything else is fine. Yeah, so here we have to check corneal sensation first and foremost. We have to make sure the eyelid's closing. That's a huge lesson, is that if you have a lot of corneal staining and your eyelids don't close, this is an eyelid problem, not a corneal problem. So with a true keratopathy, we need to make sure the eyelids close, that the corneal sensation is intact, and that they are actually making aqueous.
And let's see this. Let's say this now. Got too close to you. Okay, stay away. So Zeba, what if this patient's on 4 glaucoma drops?
So I'll usually I'll talk to my glaucoma colleagues and see which of these can be switched to a preservative-free formulation. And usually at least a couple of them can be. The other thing that we haven't touched upon yet is serum tears, which is very helpful in this particular patient population that has significant dry eye findings, but otherwise you can't really pinpoint the exact cause. And that's been very helpful in my population as well.
And then maybe for the audience, can you tell us what concentration of serum tears do you like, and how do you get them made?
So I have asked so many people their preferred concentration. I get a different answer from every person. So I use 30% QID or 20% QID. And we have a couple of local labs that will help us obtain these serum tears. Some of them will go to the patient's house and draw the blood there. Some the patient has to go themselves. And we usually pick it based on where the patient lives. And we have a couple of different facilities. We don't do it in-house.
And then, so Jeremy, say that you do diagnose this patient with neurotrophic keratitis, their sensation's down. how are you going to approach this patient?
Sort of depends how much they need me. If they're thinning, they have a big epithelial defect and they're starting to thin, one cannot underestimate the power of a tarsorrhaphy. We can talk about medicines all day long, but the eyelid needs to be closed just to arrest the issue. So if it's very severe neurotrophic keratopathy, I think the eyelid needs to be closed. Absent of that, if it's moderately severe, then I'm talking about a membrane to just try to stabilize what's going on. All the while, I've gone through every single step of my ocular surface exam. So if they're not making aqueous, then I have plugged them and I've double plugged them or I've cauterized them. After that, I'm going to start to think about something that puts nerve growth factor back on the surface of the eye, and that can be center German, that can be insulin. And then after that, sometimes we're doing more surgical neurotization than we have in the past when we need to.
Okay. And then next case now, this is a patient with pretty severe neurotrophic keratitis, decreased corneal sensitivity, and they have, to boot, a history of herpetic keratitis. Let's start with Seba. How are you going to manage this patient?
So in this patient, I would probably use Synedgerman. The history of herpetic keratitis is interesting because, in some cases, it is a chronic disease that has flare-ups and ongoing issues, whereas in other cases, it's, hasn't been active for decades. And I think kind of teasing apart where that patient falls is also relevant because you may want to start this patient on a immunosuppressive dose of an antiviral. But definitely I would treat them with Synedgerman and then consider some kind of potentially a suppressive dose of an antiviral if they have kind of chronically active disease.
Nandini, you're in Boston, where the PROS lens is from. How often do you end up putting these neurotrophic keratitis patients and herpetic keratitis patients into PROS or scleral lenses?
Yeah, I actually think scleral lenses and PROS lenses are underutilized. For these patients, I think they offer ocular surface support, but also improvement in vision, especially if they have significant corneal scarring or neovascularization from prior episodes. So absolutely, I think that's a great option. I think Synedgerman's a great initial thought if you truly feel they have NK, which they often do with herpetic keratitis. Maintenance can also be autologous serum. They could put the serum in the bowl of the scleral lens or the PROS device and continue to rehabilitate their ocular surface that way. So I've used that combination very successfully.
And Jeremy, patient walks in your office, you suspect neurotrophic keratitis. How do you check sensation?
I have a Cochet bonnet because I'm a nerd, but if I can't find it or the fellow's misplaced it, then I will take out my dental floss, which is in every drawer of our clinic. And then if for some reason it's not there, then I will take the cotton wisp and pull it out. But it's very variable. Both the wisp method depends how you pull your cotton and how I pull it. And I just like to say with both of those, we've used our dirty fingers. Clean enough fingers. But there, it's more of an on and off, a no sensation, yes sensation. So you will miss a mild NK versus a calibrated system.
Walk us through a Cochet bonnet.
It's like my heaven that someone would add. No, it's not a perfect tool, actually. And it's funny enough, to check sensation, there's an art to checking sensation. So the worst way you have a filament that you can pull out to 6 centimeters. The worst way is to take a filament of 6 centimeters and walk up to a patient and poke them because they will blink. And if you say, do you feel that? Everyone will say yes, because you believe that you should have felt it. And so the Seitzman way of Cochet bonnet is when they're in the slit lamp, I just say, just look right here, and I take it from the side, and so they can't see it coming, and then I will wheel it in.
So, but do you use a Cochet bonnet or what?
No, we're not fancy enough. I often use either a floss or a cotton tip.
All that matters is you use something.
Because I'm in the same clinic as Jeremy, I have a Cochet bonnet too, but I like your from the side technique. That is pretty cool. Okay, let's see here. Ooh, you know what? Okay, real quick, last case because we're just about to run out of time. Somebody's got gland dropout, evaporative dry eye disease. Jeremy, what's your go-to?
Evaporative lost dry eye. They're making tears. They're just going away too quickly. So this is where you're telling everybody to put their computer monitor down, to get their fan out of the way. You're talking about onion glasses. And I think it's really important to think about replacing a tear with oil in it, an oil-based tear, because they don't need to make more tears necessarily. You need to keep the tears that are there on longer.
Okay, all right. And then moving on now, because we want to give our wonderful Nandini time to present her slides. talk about talking to patients.
Great. Yeah, this is the most important part, right? We know all the treatments, we know what we could potentially offer. How do we communicate, all of these things to our patients and set expectations? So, Julie, how do you set expectations with patients? I mean, in Boston, it's pretty hard sometimes.
Yeah, I mean, I think that it's patients need to understand it's a journey, and they need to understand a lot of times, unless it's, a simple, very rarely anything's actually simple in ocular surface disease. It's a journey, and it's going to take time, and it's going to take investment, and there's nothing that I can do unless you're that lucky person who has a concretion under their lid that you take away and they're better forever, that will make things go better forever and ever, and you'll never have to think about it again. And, some patients accept that and understand that. Some patients don't. I like to tell them that, this is something that's going to be with you for your life. Sometimes it'll be good. Sometimes it'll be bad. Sometimes it'll be good. It'll kind of, fluctuate up and down. And, you know your body, you know the treatments available, especially for things like warm compresses, artificial tears, you decide when you need to use these. And if you're starting to feel worse again, think to yourself, remember, this is my dry eye disease flaring up and I need to treat it, and don't ignore it.
Yeah, and I think it's important to meet patients where they're at. I think some patients really can't stay compliant with therapies, and that's okay. And that's where maybe an interventional treatment you do in the office with some tears during the day is absolutely fine if you can, keep them at bay. So really kind of understanding what is available and what is manageable to the patient is really important, I feel.
Yeah. And to kind of piggyback off of that, you may have a medication that's working very well, but that the patient's not tolerating very well. If they're, really having burning in response to a cyclosporin concentration you're using, even though it's working great, you may not have adherence, several months down the line. And that's where I can often switch the concentration or the vehicle, so to speak, to improve both comfort and then long-term adherence.
Yeah. And what are your strategies to promote adherence, Jeremy? If you have a patient who's coming back, they're not quite using their therapies, or it's hard to kind of figure out what framework is working for them.
I mean, it's hard. Any chronic disease is hard. And I think my kids are teenagers now, but I learned from a parent therapist when they're not getting what they want, you just give them their wish in some fictitious land. And I say that all the time. I wish I could solve this for you. If I had a magic wand, I would cure this, but I don't. And you're going to have to keep taking this forever. And when at all possible, so you've assessed their situation. When at all possible, I go out of my way to say this will not blind you, because they think it will. So many people think their eyes hurt, and that means they're going blind. And so when at all possible, I'll say, I just want to remind you that you'll never go blind from this. And so many people are like, oh, thank you for saying. You think, wow, you really thought you were going blind? You look at the guy next door, he's going blind, but you don't say that. Yeah. But I do try as much to just encourage, and yeah, sure, I wish you didn't have it, but you do. And so these are the ways that let's try to fit it into your life.
Zeba, what if you have a patient who wants a premium intraocular lens and they're just not adherent with their dry eye therapy? You've brought them back for 2 sets of biometry and keratometry, but they still want it. Like, what are you going to do? How are you going to approach that conversation?
Yeah, that's an interesting one. I mean, that can be a source of motivation. You don't, look, I'm not giving you the lens unless we have stable, reliable measurements. And if it's not working, then we don't put that lens in. Because the last thing you want to do is have a patient that has significant aberrations after cataract surgery, and suddenly you're the culprit.
Yeah, I think it's important to remember, as a surgeon, you can always say no. And if the patient's really insistent, you can say, in my opinion, I don't think this is a great idea for you. It's not a great fit for you. I'm happy to refer you to somebody else to get another opinion. And you can, and I've said that before. And a lot of times when you bring up I'm happy to refer you to somebody else, the patients are invariably like, oh, no, doctor, I understand. Please don't send me to anybody else. And sometimes they're like, yeah, I want to go see somebody else. And you're like, great, okay, I'm happy to send you. Here's 4 names. Go see these people, And it is your choice, absolutely, to refuse to implant a lens.
Do you guys have any tools in your offices that you're giving to patients, like any paperwork or any informational things that you provide to patients as you kind of explain all these different treatments? It's so hard for them to remember what to do, what we talked about in clinic. Any tips?
I have a set of handout sheets basically that talks about various, kind of all the, whatever I've recommended to them, just kind of like a quick run through so they can take it home and read it if they want to, or, or not in some cases. But that, some patients really find that really valuable.
Yeah. I don't have any visuals or handouts, but I use this analogy a lot in patients who will say that, their vision's blurry minute by minute, hour by hour. And I'll tell them, look, there's not much in the eye that changes minute by minute. Your lens doesn't change, your retina doesn't change, your nerve doesn't change, your ocular surface changes. And think of it as, you're driving through the rain and you have your windshield wiper. Every minute that surface is changing. And that seems to somehow get through and patients understand the concept.
Yeah, absolutely.